Hello and welcome, everybody from across the world joining us live on Facebook for our show, Pulse by Health Job Hub. My name is Prashanti Naidu, founder of healthjobhub.com. I started Pulse to connect with all you amazing people, share incredible stories, and to be inspired. My mission is to unveil the pulse behind the pulse. Today, I am very excited. We have a very special guest on Pulse. It is my honor and privilege to welcome Dr. Ashwin Maharaj to our show this morning. Good morning, Dr. Maharaj. How are you? And thank you for joining us.
Good morning, Ms. Naidu. It's great to be here.
Oh, it's indeed our pleasure to have you. To all our viewers, Pulse by Health Job Hub is a live talk show. So if you have any questions, please ask. If you would like our show, please smash the like button and share with your network. If you can't hear us in any way, please send me a chat message. I can actually see all the messages coming up on screen. So if you're having any audio problems, definitely let me know. In response to COVID-19, Health Job Hub has opened up our platform to all employers to post unlimited jobs. We thank Health Job Hub to be a sponsor of the show. It is my honor and privilege to introduce Dr. Ashwin Maharaj. He is a fellow of the American College of Surgeons. He is a member of the American College of Colorectal Surgeons, outpatient gastrointestinal medicine, and natural tissue hernia repairs. He is a clinical lead with minimally invasive hemorrhoid therapy at Protocan. Dr. Maharaj, it is an absolute pleasure to have you this morning. Please, can you share a little bit more about your bio with us on Pulse?
Sure, I'd be happy to. Again, thank you for having me on this miserable day. I hope your weather is better than ours. I think my start in medicine, or my interest, grew from my father. My father was a GP in South Africa. We lived in a small town in South Africa. He really did achieve a godlike stature amongst his patients. And yes, that's a shot of one of our outreach clinics. I did have the good fortune of accompanying him to some of these clinics, and I remember a long drive and then attending these clinics. He was treated like a rock star. I didn't see him that way. He was my father. I didn't quite understand why he was held in such high regard. Often there would be vegetables or a bag of potatoes outside of his surgery door. As you know, in South Africa, we called his medical office a surgery.
Yes.
You know, I started to get a sense that my father was not the simple father that I came to know and love over time.
Mm-hmm.
I remember a delivery towards dusk, by the lights of our car. He delivered a child at the side of a road.
Oh wow!
My friends laugh that it's too storybook like to be true, but I was amazed, and even other stories have come out. Had been in practice here in Toronto for many years,
Mm-hmm.
and I sat down with a patient, and immediately I recognized his South African accent, and he says to me, he says, "You wouldn't happen to be the son of Harry Maharaj?" And I said, "Well, yes." And this is a man I've never met before.
Yeah.
he immediately shows me his finger, whereas like that. He shows me his finger, looks normal, and I said, well, what's that all about? He says, well, when I was a young teenager, he broke his finger playing rugby in and around Dundee, and they had a tough time finding someone. There wasn't a orthopedic surgeon available, so my dad saw him and set his finger, and his finger healed well without any problems in the long term. So I was amazed that. I mean, how does one explain that happenstance? He is a patient of my father 30, 40 years ago, and then ends up being my patient here in Canada so much later. It's just amazing.
Oh, wow. What a great story.
I over time, when we moved to Canada, I was a bit lazy in finding summer jobs, so my dad hired me as a medical secretary. I wasn't terribly good, but again, you saw the awe that his patients held for him. My mom as well has been a nurturing and caring, like any mother, and I think that with the two parental role models that I had, it was natural that I move into a healthcare field. When I was a teenager, I watched a lot of TV too much, according to my parents, even to this day, according to my wife. But that's another story. I used to watch all these medical shows like MASH.
Mhm.
You're probably too young to know what that is. It's a story of the Korean War, a mobile army surgical hospital, and all the very flamboyant surgeons who seemed to be superheroes and could take care of anything, no matter how busted up a body was. They were able to do it. And I grew up thinking, well, geez, I want to do something like that.
Wow. Yes.
Yeah.
Oh my goodness, that is absolutely an amazing story, and thank you for sharing that.
Yeah.
Photo here with this awesome car and the two nurses. Is that also your dad's clinic in South Africa?
Well, that's in a it's in an area of indigenous folk, and we had to drive out to that area. The clinic kind of moved around a little bit,
Mm-hmm.
if I remember correctly, because there were different clinics that we went to.
Yeah.
And this was one of them. Yes.
Wow.
It wasn't his clinic per
Right.
se. No.
Great. And how long ago was this, Dr. Maharaj?
I'm sorry. Say that again.
How long ago was this?
Oh gosh, that's back in the late 60s.
Oh, wow. Goodness, that's so inspiring. Thank you so much for sharing that.
No problem. I'm an old geezer, you know. That's why that's why it's so far back.
Awesome. Awesome.
But you know, I forgot to mention that you know, it wasn't just that as well. My high school, I went to high school here in Toronto. I went to Sir Wilfrid Laurier Collegiate, and I had great teachers,
Yes.
great nurturing teachers in science and biology.
Yes.
Mr. Parsons and Mr. Dursley, respectively, they both engendered in me a love of science and biology. We would bend Mr. Dursley's ear for the better part of a half an hour after every class with the wonders that the human body was. As well, you know, I wasn't, I think you asked about my passage into surgery.
Yes.
I'm not a great deep thinker. I do care about people, and I worked well with my hands, although my wife will disagree again. She finds it tough for me to hang pictures. I tend to subscribe to, measure once and hang it once and give it a try and see what happens. The hole in the wall will probably be hidden by the picture, but she doesn't subscribe to that same philosophy. But I used to build lots of models and so on, and I knew it had to be something with my hands.
Yeah.
When we first went to our anatomy class, that's where I started to really realize that that tissue and working with tissue directly was the way I wanted to go.
Yeah.
I had a great mentor. His name was Dr. Stanley Dudrick. He actually invented feeding by vein. He never got the due reward that he should have. He should have gotten the Nobel Prize for that, but he never did for a number of different reasons. But he had a very great faith in us as a group and me individually. I'll never forget myself and Dr. Zahir, a plastic surgery friend of mine,
Yes.
who we trained together, and he and I and Dr. Dudrick removed a carotid tumor from a man's neck, and it was very touch and go surgery. But he had faith in us, and we were only third-year residents at the time.
Wow.
And it was a great confidence boost that he gave us, and that all of that training has stuck with me today, and that's how I ended up in surgery.
Oh, wow. That is absolutely an amazing and fascinating story. And thank you for sharing that. And I know you've mentioned your wife, and did you meet her in medical school as well?
Yes. We both graduated from the Royal College of Surgeons in Ireland, in Dublin.
Oh, wow. Goodness me. So you are definitely a medical power couple, I would say.
Well, she'll disagree with that. She thinks that she's the power behind the corporation. I just bring up the rear.
Oh.
In more ways than one, we'll find out later. That's where I tend to do most of my work, in the rear.
That's great. In fact, I have some comments from our viewers coming in, and Lisa Chetty says that it's an inspiring story, Dr. Maharaj. She wants me to share that with you. And there's a few other comments coming into our chat as well, and everybody is so excited to hear your story. So thank you so far for sharing. You are currently the lead, or you're actually leading the way in minimally invasive anorectal surgery in Canada. Please share your story about why and how you started this new procedure in Canada.
Sure. Well, all general surgeons are trained to do a number of different operations and to deal with a number of different problems. And anorectal surgery is one of them. Anorectal surgery not only is the purvey of colorectal surgeons and general surgeons, but also of GPs. It's one of the most common conditions in general practice and general surgical practice.
Yeah.
3 out of 5 people in the Western world are afflicted by by problems down below. And for example, more than 1 in 3 people at any time in most Western countries have ongoing problems with their bottom. As many as 50% of those aged over 50 are affected by this. So over a long period of time, astute, I didn't really like taking care of it because it was so fraught with trouble, with pain. If you operate on the anus, it's that nozzle. Everything is going to come through there within a day or 2 after surgery, and it's going to hurt and swell, and you will curse your surgeon. And we as surgeons don't like dealing with it. We as GPs don't like dealing with it. So we tend to pass it off, and the last person in the line has to take care of the problem. And for a long time, for maybe 70 years or so, all we had in the way of conservative treatments are things like creams, suppositories, and the more aggressive procedure is a rubber band. You can, as this cartoon depicts, the bottom really doesn't get that much attention. And when people suffer, nobody wants to deal with it. So there's a great stigma, and nobody wants to talk about it either.
Yeah.
It's a very it's something that nobody wants to talk about. If we can go through to the next slide, when people suffer with things like hemorrhoids, for example. First of all, this slide right here on the left, I think it's just hidden by the address bar. That's better. So if you can see this picture on the left, this is actually a picture of the internal rectum.
Okay.
You can see the scope on the top left-hand corner with the black tube. So that tube goes in, and we turn around and go backwards, and now we're looking at the anus. That's the exit of the rectum down to the anus, and that's a normal anus, a normal lower rectum. Okay. So this is what big prominent hemorrhoids look like.
Oh wow! Goodness.
Yeah, these are. It's not that smooth area that you saw previously. This is a direct look going in. You can see these big bulbous. They're grapes. They're full of blood.
Oh wow!
Each of these individual hemorrhoids are fed by an individual blood vessel.
Wow!
So you can perfectly understand that if one of these break open, say you have a hard stool or whatever, it tends to bleed a lot or swell. And that's basically the symptoms that people have. Swelling, bleeding. These things can get so big that they actually prolapse out. They come out of the anus. Wow. Sometimes people don't do, again, you don't want to touch down there. They suffer through it. They maybe use some creams, and it slowly goes back over many days. Sometimes immediately if you're lucky. But others have to actually physically push this prolapsing hemorrhoid back in. Now, the option for most general surgeons throughout this country, most colorectal surgeons, the first option, the first aggressive option, and I would say mildly aggressive, this is a mild procedure, generally where we put a rubber band. If you can take a look, so that heart-shaped area already has a rubber band around it, and that rubber band will trap some hemorrhoidal tissue, and we then apply a freezing probe to it. So it's called rubber band ligation and cryotherapy. The whole idea is to cut off the blood supply that's going through this hemorrhoid.
Wow.
Unfortunately, you can see it's covered with mucus. It will generally just slip off.
Oh.
Some estimates are anywhere from 10 to 25% effectiveness for this procedure. So if you remember from the previous picture, if you have hemorrhoids that go all the way around, you're going to be seeing your doctor forever. If you take a look at this picture, this is the not that smooth area, that normal hemorrhoidal picture, but you can see these very large hemorrhoids seen from the inside of the rectum. Again, you can see the scope in the top left-hand corner.
Yes.
So the first step is rubber bands. And if that does not relieve your bleeding, swelling, pain, itching, and prolapse, then the only option from a surgical standpoint is to cut these out. And just that thought of anybody going with a knife to cut these things out, and everybody's heard horror stories. So it really puts a fright into these patients who suffer this way. Starting about maybe 30 years ago, it was thought that we've got to find a better way of doing this. The first hemorrhoidectomy was done in the 1930s. Milligan and Morgan surgeons from St. Mark's Hospital in London did the first operation. And there was very little adjustment ever since. We tried to cut these hemorrhoids out. This is a picture of hemorrhoids on the outside, and this obviously will have those hemorrhoids on the inside as well.
Mm-hmm.
So if you cut these things out, it's going to be hurt and be quite sore.
Yeah.
And most people didn't really want to go for this.
Yeah.
So about 30 years ago, Dr. Morinaga, I believe he was a Japanese surgeon who came up with the idea of using Doppler ultrasound to identify the blood vessel that feeds each of these things.
Mm-hmm.
Now, what you can visualize this is if you have, say, a carpet or a mat,
Mm-hmm.
and you have a balloon that's blown up. Inside the balloon is a bunch of grapes. Underneath the carpet is a pump and a tube that goes into the bottom of these grapes and fills these grapes full of blood.
Mm-hmm.
Okay, and the more constipated you are, the more you're a female. If you've given birth several times, if you have trouble with difficult birth of your children, etc., you develop these hemorrhoids.
Mm-hmm.
And the only choice up until the mid-90s was cutting out these hemorrhoids.
Right.
So Morinaga came up with the idea, let's look at this more elegantly. And he came up with a very elegant solution. Use ultrasound to actually identify where that feeding blood vessel is traveling underneath that carpet.
Yeah.
When we're able to identify it, we can surgically tie it off right through the carpet. We don't have to cut. We just tie it off.
Right.
And I wish I could show you a video of it. But in some cases, when you nail it, when you find this ultrasound signal and you suture ligate it, it's just like sucking a balloon dry. It just completely collapses. So he came up with the idea, well, if we do that, maybe there's no need to cut anything out.
Yeah.
And that's exactly what we do. The subsequent shots here will, these slides will sort of illustrate that a little better.
Great. Wow. Those slides that you just showed us are absolutely fascinating. I don't think I've ever seen that before. And you've really enlightened me and taught me something new today. So thank you. Thanks for sharing that. But please could you also share your experience in relation to outpatient endoscopy in Ontario?
Sure. Well, outpatient endoscopy was quite prevalent before COVID-19.
Mm-hmm.
We have shut down all these clinics that are at high risk for patients as well as staff.
Yes.
As a result, we've stopped doing this procedure.
Yes, absolutely. I agree. This is difficult times and changing times. Could you maybe elaborate more about the paradigm shift in hemorrhoid treatment in Ontario and Canada?
Well, it's basically what we're discussing. If you could put up the subsequent slides.
Yep.
You can keep going. That's a nice picture of somebody's bottom. Looks like a pear. That's another one. And this is a bottom that's not happy with some sort of hemorrhoidal set of symptoms.
Okay. So would you like me to show the hemorrhoid photos again?
No, the other ones.
Okay.
Do you have the other ones?
Right. So I'm going to show, you can tell me which one to add.
No, I don't think you have it. Anyway, we can proceed without it.
Sure.
Basically, the paradigm shift is exactly what I was talking about before. There's no need to cut anything out. Identify the feeding blood vessel, tie it off, operate well above the anal canal itself, come down to the apex of the anal canal, the top of the anal canal,
Yeah.
grab a hold of the hemorrhoid and pull it up and put it up where it started off, higher up in the anal canal, just at the bottom of the rectum.
Right.
So there's no need to cut anything out. That's the paradigm shift. Up until now, as you know, most surgeons have a innate desire that if something is not required or it's too big or too bad or malignant or whatever, we cut it out.
Right.
This is one situation where we use this elegant technique where we tie off the blood vessels and then move it to a higher position in the rectum. That's the paradigm shift. It's called hemorrhoidal arterial ligation. There's another term. It's also referred to as THD, transanal hemorrhoidal dearterialization. So that's the paradigm shift.
Okay, well, thank you for sharing. And I actually know which photos you want me to share, and we could do that as part of sharing this link. We could add that bit of it when we are sharing this video, so people could actually see what you are talking about in terms of the new procedure you are currently doing. So in creating Pulse, one of our goals was to have our finger on the pulse. So with regard to the widespread global pandemic COVID-19, you've already just touched on that briefly, but are there any gastrointestinal symptoms associated with COVID-19 that we should be aware of?
Yes, we are learning lots more about COVID-19. We all know about the cold flu symptom syndrome, runny nose, congestion, sore throat. The earliest symptom is a loss of smell and a loss of taste. Those are the classical ones. And then of course the chest pain and difficulty breathing with the more advanced cases.
Yeah.
And that's what each country has experienced. At first we get the very early cases, and then we start to experience more and more of the more advanced cases that are out there in the community, thinking that they have a mild COVID-19 or just a regular cold or flu, which is still out there. So one of the aspects is diarrhea and abdominal pain.
Yeah.
Many of these patients, as part of their syndrome, have experienced some upper abdominal dyspepsia, some pain, and some diarrhea.
Yeah.
We always knew that, especially in children, when you develop an upper respiratory tract infection, you can develop abdominal pain and diarrhea. The one thing we don't know is that whether COVID-19 can actually be transmitted through the GI route.
Exactly.
We've always thought that it was droplet transmission through physical contact. Obviously it can be suspended in the air, and as long as you are about 6 feet away, that droplet will hit the surface, preferably the floor, before it hits your nose. So we're not exactly sure about the abdominal side of things, but bottom line is you just listen to what your mother told you, which is, if you're coughing, sneezing, wash your hands thoroughly. 20 seconds with soap, preferably, if you can't find that. The old hand sanitizer. Hopefully your grocery doesn't gouge you. You're like one of our high-end grocers here. gouged us severely, which is a really despicable thing to do.
Yeah, I saw that on the news, and it is absolutely despicable what they are doing to innocent people during this time of need.
Yes.
Definitely be nipped in the bud before it starts again. What is the state of COVID-19 infections in Ontario? And what is your medical advice for all of us who are afraid of this virus exploding
Sure.
in Canada and across the
Sure.
world?
Well, as of today, here, just kind of going big to small, in Canada, we have almost 6,000 cases, 5,600 and some odd.
Wow.
In Ontario, we have the second most. We have just over 1,000, around 1,100 cases, with 19 deaths here in Ontario.
Yeah.
In Toronto, we've had about half a thousand, about 500 in Toronto itself, with 4 deaths.
Oh.
The changing aspect to it is that up until very recently, we were seeing a lot of people flying in with the disease and bringing it from elsewhere. Any one of the other hotspots, the United States, Europe, China, etc.
Yeah. Yeah.
However, currently the transmission in Ontario is community acquired. So the cases that we do have are starting to circulate, and that's when we're going to start to see the next spike in this disease. We must keep this the numbers in check. We'll frighten you at first a little bit, and then I'll take it away. COVID-19 right now has killed more people in Canada than SARS did. Back in 2003, only about 44 people died from SARS. SARS was highly lethal. If you got it, you were done for.
Yeah.
We've had many nurses, doctors, ICU doctors who succumbed to it here in Toronto.
Yeah.
With respect to COVID-19, COVID-19 must be looked at in terms of a give and take. On the one hand, yes, we have lots more deaths.
Yes.
But on the other hand, the give that it gives us is that if you do have it and you don't belong into a high risk category, it's likely that you will have mild disease. You have to make sure that you self-isolate and take care of yourself, just like your mother always told you.
Yes.
Rest, but not too much.
Right.
I think personally that we rest too much. I think I talked about this in the beginning, where I tend to work a lot with my hands, and I work mechanically, and I think mechanically, and the lungs also work mechanically. They work medically, yes, and they succumb medically, but COVID-19 and any other flu-like illness, a lower respiratory tract infection, either bacterial or viral, the viral cascade of inflammation inside your chest, it will choke off the air containing sacs. But as long as you maintain good hydration, keep moving around, not a ton of rest, not a ton of moving around either. Don't start running a marathon or anything like that.
Absolutely. Yeah.
Regular, don't just lie down on your back on one side. Don't lie down on your left side, or if that's the way you like to sleep. Okay. You need to be up and about, and you need to get those secretions out. Okay. And you need to keep the airway clear. The key is to buy yourself enough time for your body to recover. The body's a brilliant piece of machinery. Okay, it works magnificently. If you give it enough time, it will vanquish the COVID-19 that you may have.
Yes.
But the key is very simple stuff. Keep yourself well hydrated, nourished as well.
Yes.
You don't have to force yourself, but don't not eat.
Yes.
You have to, you need the energy to survive.
Yes.
Stay away from what's that non-steroidals like ibuprofen.
Yes. Yes. Yes.
Not 100%. It's a small French study that alluded to it.
Yes.
Use Tylenol mostly.
Mm-hmm.
Remember that the average age adult can use a maximum of about a gram, 1,000 milligrams of Tylenol 4 times a day.
Okay.
Okay.
Right.
So, if you're smaller, then you can use a little less, maybe a gram 3 times a day.
Okay.
To get that fever down, make you feel better.
Yes.
The key is to keep well hydrated, and as long as you do that, you give yourself the best chance of surviving an infection. But remember, there are people that are at risk. I'm one of them. My colleague from medical school, he had lymphoma, he had chemotherapy. He's at risk. He's immunocompromised. If you're taking steroids, you're immunocompromised. If you have asthma,
yes,
or COPD,
yes,
I have asthma ever since I was a child.
Right.
But I haven't needed a puffer very much, but I'm at high risk as a result as well. I don't know if you can see, there's a little gray hair there. So when you're older and you have these risk factors, you're at higher risk. You need to be very careful. The key is to stay at home.
Yes.
Stay at home. Don't make yourself a patient.
Yes.
Do not. The worst is yet to come.
Yeah.
But we can weather this if we do the simple stuff like we talked about, the keeping yourself clean and so on.
That is excellent advice. And if anybody missed this, the Tylenol advice was you could take Tylenol. If you want to repeat that, how many grams, Dr. Maharaj? And how?
Yeah, it's about 3 to 4 grams.
Yes.
3,000 to 4,000 milligrams a day.
Milligrams a day. And that could really help you with the fever if you have it. And another great piece of advice, stay at home and keep hands washed. So, thank you.
That's right. Keep well hydrated. Yeah, all that stuff.
That was excellent advice. And I'm hoping that all our viewers would take heed to that. I've been watching on the news. The healthcare frontline professionals have really been getting, brunt of this COVID-19 pandemic. They've really had a difficult time. Can you describe what the impact of COVID-19 on frontline medical professionals is like yourself, even?
Mm-hmm. Like any war that we fight as a country and as a people, some people are on the front line. You either carry a rifle or you carry a stethoscope, paperwork, or a mop in a hospital. Mm-hmm. These frontline workers deserve our highest regard. Mm-hmm. I felt very guilty that I'm sitting at home isolating, and my colleagues are out there slogging away in emergency departments and intensive care units. I'm looking to help out, but I'm told that so far, we have things under control. I think the greatest error, I think, both south of the border and elsewhere in the world, is the lack of preparedness. Mm-hmm. We get constant taps on the shoulder. Mm-hmm. We have MERS and SARS and Spanish flu and now COVID-19. Mm-hmm. What happened to COVID 1 through 18? That's another story. It's named for the year 2019. it's it we are very poor students of history, very poor students of history. We don't respect history. We don't learn from it. We don't keep it close to us and listen to people who are versed in it. We knew that something like this was coming down. Here in Canada, I think we are much in a much better situation than, say, in the United States. They seem to want to deny that anything bad is going on at all. Whereas as soon as we started to hear about it elsewhere, we started to gear up.
Yeah.
Perhaps there were some errors too in terms of lockdowns might have occurred a few days earlier, et cetera, et cetera. But by and large, we've done a great job from the leadership on down here in this country. But the frontline workers, my brother-in-law is a colorectal surgeon in the Midlands in the UK. They've basically stopped all his elective surgery, even people with cancer.
Yes.
That's elective.
Yes.
It's urgent. It's not emergent. You don't have to do it right away.
Yes.
You have to do it soon.
Yes.
But they've put him to work in intensive care units in areas of practice that he's not used to. He's a colorectal surgeon. He's a bum doctor.
Yes.
So forgive me, Amit, if I refer to you as a bum doctor. Actually, he was the one that introduced me to HAL and THD.
Yes.
In terms of treating hemorrhoids. He was the one that first told me about how successful a practice he had at helping patients with these hemorrhoidal symptoms. Anyway, cut a long story short, he's on the front line in the intensive care unit, taking care of these high-risk patients.
Yeah.
And these frontline soldiers will put themselves in harm's way. Your viewers on Facebook can look at my Facebook page. One of my colleagues, I believe, is aware of a friend of his or hers in Italy,
yeah,
who succumbed to COVID-19.
Yes.
You have a young nurse in his 30s.
Yeah.
All he had was a little bit of asthma, and he's gone.
Yeah.
So, it's they are the fallen ones, the true heroes.
Yeah. No, absolutely, and we salute all healthcare professionals across the world that are working in COVID-19 and trying to help save lives. Thank you so much for all the work you do. I know I speak for millions of people. We really appreciate everything you do when you go out there every day to help save lives. Thank you. Well, thank you, Dr. Maharaj, for enlightening us this morning and sharing your incredible story on Pulse. You really brought energy to the screen. Thank you so much. I really, really appreciate having you.
My pleasure. It was a pleasure.
Absolutely. This brings us to a close of our Facebook Live show for Pulse by HealthJobhub. I do hope you enjoyed the show as much as I did. Please join us next week, same time on Facebook Live. I'm excited to announce that our special guest joining us next week is Dr. Haroon Suleiman, general practitioner and family physician, who's going to be coming and broadcasting live from Brisbane, Australia. And he's going to be sharing with us his experiences of being trained in South Africa, moving to Ireland, and now practicing in Australia, and also sharing his thoughts on COVID-19 with us. Thank you so much, everybody. I hope you enjoyed it. Please join us again next week to be inspired. And don't forget, if you enjoyed the show, smash the like button and share with your network. Thank you. God bless.
Bye-bye.